All right, I think we can get started. Thank you everyone for joining us today for our cardiology grand rounds. This week we have the honor of hearing from our own Dr. Theodore Abraham on the topic of advances in hypertrophic cardiomyopathy management. Dr. Abraham is a professor of medicine in the Division of Cardiology at UCSF. He completed his cardiology fellowship at UT Southwestern with advanced echocardiography training at the Mayo Clinic. Dr. Abraham now directs the UCSF Adult Cardiology Cardiac Echocardiography Lab and co-directs the HCM program, a designated center of excellence. His research focuses on early diagnosis and risk prediction in HCM, utility of strain echocardiography, and monitoring disease progression and prognostication in a variety of cardiac diseases, particularly cardiomyopathies and heart disease and athletes. Dr. Abraham is a co-PI of the Explorer HCM trial, studying the effects of mavacamten for symptomatic HCM. He has received numerous research grants and awards for his work, and he serves as an AHA councils on clinical cardiology and basic cardiovascular sciences, and is on the editorial boards of the JASE, JAC cardiovascular imaging, and CIRC cardiovascular imaging. So with that, I'll turn it over to Dr. Abraham. As a reminder, please put any questions that you may have in the chat, and this will be recorded and available on our YouTube for view later. Thank you.
Thank you, Joyce. Appreciate that very kind introduction, and I'm excited about speaking with all of you about hypertrophic cardiomyopathy. I do not have any financial disclosures. However, I will be discussing many of the trials that you referred to that I'm involved with in some way or the other. But let me start by saying this is a very large team effort, and starting with Roselle and Kate, who see most of our patients in HCM, and a whole host of other folks. None of our success would be realized without these great people on our team, and multiple other parties, Matt, Isaac, and the sonographers and the HLT techs, Erica with CPET, our research fellows, who I'll talk about later, Kirsten, Brenda Marr, and the ambulatory team, and of course the leadership, including Liviu and the clinical trials leadership, without whose help we would not be where we are. Here are some of our learning objectives. And I'd like to start with a small introduction to hypertrophic cardiomyopathy that most of you already know. It's a very common genetic heart disease. In fact, it is thought to be the most common inherited heart disease, occurring in about 1 in 300 folks gene positive, and maybe 1 in 400 or 500 with actual phenotype. And the worldwide burden is thought to be about 20 million. It results from mutations in genes encoding for sarcomeric proteins. Here are some of the common ones that I'm listing up on the figure there. And the interesting part is that most folks with carrying the gene or even manifesting the disease have a normal, healthy lifespan. But there are some folks who might experience complications that include and are not limited to angina, heart failure, arrhythmias, including sudden cardiac death. Hypertrophic cardiomyopathy has certain key features. Ventricular hypertrophy, as the name suggests, mostly septal, but could occur anywhere else. Systolic anterior motion, and the resultant outflow tract obstruction. However, the most interesting part here is that all these features are variable. So you may not have hypertrophy, you may not have outflow obstruction, you may not have systolic anterior motion. There's a significant variation in the degree and location, and then the presence and absence of any of these features. Another very interesting feature is, for most part, the function is normal or hyperdynamic. This is left ventricular function. So in fact, having said that, HCM is a very unique cardiomyopathy because it's almost a non-cardiomyopathy, because at rest, the heart function is very normal. With stress, including exercise stress, the heart function is hypernormal. So it's tough calling it a cardiomyopathy when on the surface, everything looks really good. So conventional functional assessment is not useful, and there are highly variable features. So the evaluation of an HCM patient is especially and uniquely individualized. And as a result of that, HCM, I would say, is custom designed for imaging. And there are multiple types of imaging, whether it's looking at the morphology or characterizing tissue, looking at function, including sensitive function, functional assessments such as myocardial mechanics, or going even one step deeper and looking at microvascular perfusion. And all steps in this HCM journey, from diagnosis to risk assessment to prognosis, all are touched upon by imaging. Here are some of the features. You see SAM, look at the mitral valve, which is longer than usual and tends towards the septum. Here's another close-up view. Again, SAM, a mitral valve that is coapted and then tending or meeting the septum. Here's someone with severe LVH and no classic SAM. Here's someone with obstruction. There's mitral regurg coming down in the left atrium. There's obstruction based on color. Here's somebody with SAM occurring more distally at the pap muscle or chordal level. And lastly, here's another variation, which is very mild hypertrophy, maybe 1.3 or 1.4 centimeters worth of hypertrophy and no SAM. And we'll talk about this gentleman shortly. We do contrast in almost everybody. One, because we want to know the severity of LVH. This is someone who we thought for many years had maybe a 1.5 centimeter septum, but with contrast, we found that his septum was actually 4 centimeters. That has huge impact on whether they're going to get a ICD, for example. Here, right here in the top right-hand side is someone with extreme HCM, again, a 4 centimeter septum. And there's nothing great here except that you can see that the contrast has actually gone into these dilated, profuse capillaries in this hypertrophied septum, and you sort of have a starry sky appearance here with actual being able to see capillary flow there. The bottom left-hand side is someone we thought had apical HCM, but contrast was able to rule that out. Even with contrast, the images are not great, but you can see that there is no septal hypertrophy. Lastly, this is a gentleman that we thought had concentric hypertension-related hypertrophy. And with contrast, again, tough images, but with contrast, you can see that the base is mostly thin and the hypertrophy starts at the mid-level and extends into the apex. So this is classical mid to apical hypertrophy. So what is the diagnosis? The current guidelines suggest that the diagnosis of HCM is made purely by septal wall thickness. That's 15 millimeters or more. And the caveat there being that if you are 13 millimeters in the setting of family history of HCM or gene positive for HCM, one of the causative mutations, then you could still fall within the realm of hypertrophic cardiomyopathy. And then we look at gradients. The magic number is 30. And you split folks into obstructive, labile or latent obstructive, and non-obstructive, depending on whether your gradient is above 30 at rest and with provocation, or if it's less than 30 with rest, but increases provocation, as this example shows here, or non-obstructive if both at rest and provocation, your gradients are less than 30. This is another modality, MRI, which has exquisite anatomic detail and can also do tissue characterization, as I'll show in the next slide. Someone with significant mid-ventricular hypertrophy, not much SAM, and actually did have some obstruction, but impressive mid-ventricular hypertrophy. But most interestingly, the anatomy is so obvious visually. If you have metal or devices, it could be a problem. And hemodynamics is still a challenge with MRI, although there are techniques. This is someone with late gadolinium enhancement. If you look where the circle is being drawn, that's the hypertrophied part of the septum, very thick septum. And then on this side, you can see that there's co-localized scar, which is very patchy. Unfortunately, may not be very clear in this picture here. Moving on to ammonia PET scanning, which is the gold standard to look at microvascular problems. It identifies patients with perfusion abnormalities much better than SPECT. We've had significant numbers of patients who've had a normal SPECT scan and then a very abnormal PET scan. And again, here you can see that between rest and stress, there's a drop in perfusion in the septum. And typically that's co-localized with where there's most hypertrophy and also co-localized with scar. And I'm not going to present any more data on that or too much more data on that. Cardiac mechanics is another very important aspect because, as I said, the heart function looks normal at rest and with peak stress. So you do need something more sensitive. And cardiac mechanics is where you use non-visual means to track the mechanical motion of the heart. And this could be with classical tissue Doppler, which is where you track a single point in the heart. And you see the classic S prime and E prime and A prime waves, or strain, which is tracking deformation, where you're tracking the change in length of a particular segment. Sorry, I should have shown you a strain there. And if you look at the bottom here you're tracking one single point in the heart. And with strain, what you're doing is tracking how a particular segment behaves. So here again, you look at shortening or lengthening of a particular segment. So strain rate and strain are even better because they look at deformation versus just displacement of a single point in the heart. So this is the example I gave you or showed you earlier. 16-year-old kid plays football and basketball, has a non-specific T-wave changes on EKG in a pre-participation physical in his high school. Also, I had an ultrasound that showed normal wall motion, normal EF, no SAM, but a 1.3 centimeter septum. So this is his long axis view here on the right-hand side. So we did strain in this gentleman, and he had a, again, normal appearing apex and a borderline basal LVH. And these are strain curves. The light green is off the base, the yellow is off the apex. And interestingly, what you will see is that when there's normal contraction at the apex and normal strain, which should be more than 15 or 18%, you see that there's really not much contraction at the base, which is hypertrophied. In fact, it may even be a little dyskinetic or stretch when it should be shortening. And secondly, when the rest of the heart is relaxing, this septum actually mounts a very weak late contraction, about 5% of strain. So we thought, well, we don't know, this might be an artifact. We measured it multiple different times, got the same result, called him back in a few months, and he got the same result again. So we decided to screen his family and do genotyping. And interestingly, he came back with a myosin heavy chain mutation, and his mother also was gene positive and had a very mild septal hypertrophy as well. Interestingly, his sister was negative. So how do we manage HCM? And I'm going to focus mostly, for most part of the discussion, on obstructive HCM, because 2/3 of the patients have obstruction either at rest or with provocation. So if you meet guidelines criteria, we typically offer medical therapy, beta blocker, calcium channel blocker, with or without disopyramide. And I'll talk a little bit about some of the novel therapies. And if you fail all these therapies, we would ordinarily recommend some form of septal reduction. And the initial form of septal reduction was a septal myectomy. The classic was the Morrow myectomy, done in first in Bethesda, where they use an instrument called a pituitary rongeur and create a trough in this very hypertrophied septum. But as you can see, if the trough is not well made or there's hypertrophy elsewhere, you could have a significant recurrent gradient. So Gordon Danielson and Hartzell Schaff and the rest of the folks at the Mayo went ahead and did what's called an extended myectomy, where they do not do a trough, but they keep slicing the septum as much as they can from the base right down to the pap muscle, and then as much as side to side. And this is done in various different ways. And in addition to this, this extended myectomy includes cutting off any accessory cords that might be causing problems, a papillary muscle that might be causing problems, a muscularized cord that might need to be excised. And also lately, they've been doing what's called a transapical myectomy that I'll show you an example of. What if you are not a candidate for a myectomy? Now, if you are older, you have a preference not to have a sternotomy, or you're higher surgical risk, you might end up needing an ablation. But if you're younger, low risk, there's local expertise with surgical myectomies, or you have a multitude of anatomic factors that need you to have a myectomy. You have a valve problem, you need a concomitant bypass, you have cords, pap muscle, and aneurysm to be addressed, you have mainly apical or diffuse hypertrophy, then ablation is not going to help you. And lastly, if you've had one or more previous ablation, then you probably need a myectomy. So let's start with alcohol ablation. As you know, in the cath lab, they get into a septal perforator. In this case, you want to get a septal perforator that subtends or supplies and perfuses the basal septum. And hopefully that is the point of maximal contact. This is a patient that we did in Baltimore on the cath table, had a resting gradient by echo of 102. right after ablation. And you can see that when you ablate with alcohol, the interesting thing is alcohol is a very strong ultrasound contrast agent. So you can see exactly where they ablated, which is a perfect spot because it coincides with the maximal hypertrophy and the point of septal SAM contact. And you can see that there's an instantaneous reduction in gradient from 102 down to 12. This is literally within a few seconds. However, you may not have infarcted the myocardium, only stunned it. In that case, in about 6 months or so, the gradients may reappear. And at that time, you might need to either reablate or send them for a myectomy. What if you don't want to have an alcohol myectomy? Some people have used radiofrequency ablation, and this can be done either endocardially, as shown on the left-hand side, where you go in classic endocardial fashion, use RF ablation catheters, and you can see the scar here in the basal septum. Or in China, they've started going intramyocardial from the apex with ultrasound guidance. You see the ablation needle right here. And then once it's ablated, you see it's very echo dense. And you can see in both cases where the yellow arrows are pointing to that the gradients come down and are down at 6 months and certainly, at 3 months or 1 month, and then prolonged at 3 to 6 months. I'm going to switch gears here and say that while we've talked about a classic basal HCM causing obstruction at the LVOT level, there are multiple forms of HCM, and I'm not going to touch upon many of them, but this is a 60-year-old gentleman who lived in Baltimore, did not have a diagnosis of HCM, but had hypertension and dyslipidemia, was raising a toast at his nephew's wedding and thought he had too much scotch. He was lightheaded, diaphoretic. His son took him to the closest ER, which is a Bayview ER, and they found him to be in monomorphic VT, still walking and talking. They cardioverted him, and at that time did all his labs and found that he had a minor troponin leak, an EKG that looked like an acute MI. So like all good cardiologists, they sent him over to have an angiogram. And like all good interventionalists, they did not find any major coronary stenosis, but they found a small stenosis in a small PDA branch that they went ahead and angioplastied and asked for an echo the next day. And this is the echo the next day. And our sonographer started with the peritoneal long axis and called us in saying, this does not look like a post-MI echo. In fact, it looks like an HCM echo. You see that there's this significant hypertrophy. There's complete LV obliteration in the mid cavity. And then if you look at this cross section, again, complete cavity obliteration. If you look at the arrow here, there's color flow Doppler suggesting high velocities. And then if you go more apically, there's this strange looking echo density sitting in the apex. Typically, you should see a complete donut without anything in the middle. And you see that there's something there which is echo dense. So they went ahead and did even more images. And if you look here, it's very instructive. Let's start on the left-hand side. There seems to be an echo density on the top that is reproduced on the orthogonal view. And then if you see this high color jet there, or high velocity jet, if you look at the velocity, it's actually very high at rest, 110 millimeters of mercury at rest. So this is just a schematic to show you there's a clot sitting in the inferior apex, and then there's very high velocity just shy in the mid to apical neck where this hypertrophy is maximized. So we went ahead and did an MRI, and you can see here in the MRI, hopefully you can see this well, you see significant midventricular and basal hypertrophy, a scarred and thinned apex, very thin apex, about 0.3 centimeters in thickness, and then a density right there, which looks like a clot. Now it's enhanced here in the still image on the right. You can see the clot right there and the severe LVH in the middle here. So of course he had an ICD placed. He was sent home. He came back in a few weeks and had a pretty involved surgery, which started with the classic basal approach and did a basal debulking of the septum. And then the surgeon went in through the apex, excised the scarred apex, did a thrombectomy, removed the thrombus, debulked what they could of the remainder of the septum and the other walls, and lastly, sewed the healthy parts of the LV together and supplemented that with a pericardial patch. He did really well, and at least until we were in Baltimore, he was following up with Roselle and did extremely well, and was back on his boat on the Chesapeake Bay without any problems. So yes, we can do all that, and we can use the scalpel with great abandon. However, there are several new drugs that might give you pretty much the same effect. And this is about modulating the cross-bridge mechanics, and that's where most of the focus has been. So as you know, the heart contracts because actin and myosin interact, and you have the myosin head pushing the actin filaments together, causing a contraction at the molecular level. In HCM, in transgenic mice, you have, or others have noted, that there's been a significant increase in the power stroke with lots more percentage of cross bridges. So let's say in a normal person, 50% cross bridges are effective. In HCM, it could be 90%. And these cross bridges don't dissociate as easily. So mavacamten is a selective modulator of cardiac myosin ATPase. And in animals, they found that it weakens the power strokes, it allows fewer cross bridges to interact, and it hastens the dissociation of the cross bridge. And again, in animal studies, it was able to prevent left ventricular hypertrophy. And in fact, if you went down to histopathology, it reduced myocyte disarray and reduced fibrosis. So it seemed like an interesting drug, and they started with an early phase 2 clinical study with only 11 patients, symptomatic with high gradients, and the primary endpoint here was LVOT gradients. And you can see that with drug therapy of up to 12 weeks, there was a significant drop in gradient. And when you washed out the drug, there was a reemergence of the gradient within 4 weeks. So on top of that, they found that mavacamten was very safe and effective. You can see that the exercise gradient started off at 125, the average gradient, dropped down to 19. This is better than surgery, I would say. 10 out of 10 had some reduction in gradient. 9 out of 10 had their gradient reduced to less than 30. So definitionally, it'd be non-obstructive by week 2, and at least 8 of these 9 patients had persistent decrease in gradients, and most of them were well tolerated with very minor side effects. So around that time, the UCSF HCM Center got started, and we were able to constitute a very top-notch clinical trials team. And these are some of the folks. The top 4 are with us right now. The bottom 3 were very instrumental in helping us launch this. And then, of course, I also want to recognize Diane, Bombi, and Rohit, who've done a lot of research in HCM, and they will be presenting their data in separate forums. So I'm not going to touch on that. And I certainly want to recognize the folks who have volunteered their time, whether it's Rajiv Mason, Ramses, Ariana, and Angie. And I would be remiss not recognizing the efforts of Cynthia, Carol, Ben Hobson, and the clinical trials unit, and of course, Dr. Klein, for all their support, because a lot of what I'm going to talk about from now on is predicated on their support. But none of this could happen without some very key people that are mentioned here, Dr. Tolstrup, Qasim, Watt, and Sabanayagam, who have read all the echoes and served as co-investigators on every single study we have done and have really helped us achieve a huge amount of success with these trials. So the first one I'd like to talk about is the Explorer study that was reported in September of last year. It was the largest randomized controlled study in HCM, enrolling about 251 patients across 68 sites in 13 countries. Patients were randomized to 30 weeks of mavacamten versus placebo, a whole host of endpoints. And again, thanks to all the folks that I just mentioned and recognized, UCSF was the #1 US enroller for this study and #4 worldwide. What did that show? That rest gradients went down substantially. Ejection fraction, which was monitored, went down very little, but did not change throughout the course of the study. And there were significant drops in NT-proBNP and high sensitivity troponin. Mavacamten, again, was safe and effective. There was an improvement in at least one class in 65%, and 50% of the patients went to a class 1 status. This is New York Heart class. 74% went down to below 50 millimeters of mercury and 57% below 30. And most of them had an average increase in VO2 max. All this was with a very low dropout rate. In fact, no participants withdrew due to reduced EF or symptoms of heart failure. Very low serious side effects. In fact, there were more serious side effects in the placebo arm versus the mavacamten arm. And lastly, we were all concerned about AFib, and there was no difference in AFib events between the placebo and the treated arm. This is an example of a patient that we had right here, 60-year-old lady who prior to MAVA, you can see she has a thickened septum, significant SAM. Bottom here, you see a lot of obstruction by color, and I'll show you the Doppler in a second here. You can see Doppler rest is 130, Valsalva 150. Again, remember, normal is less than 30. And then significant MR, you see this very nice eccentric MR going down the back wall of the left atrium. After mavacamten, these are the gradients. Rest 130 down to 8. Valsalva 150 down to 12. This is after 4 weeks of therapy. And why? Because if you look at the post images, SAM has gone away, completely gone away. And if you look here, there is no color evidence of obstruction, of course, validated by the Doppler here, but almost no MR. So these are fantastic results, having seen at least 19 years of folks going to surgery and on high dose of diazepam and beta blocker. This was just amazing results. So we're now involved in Redwood, which is cytokinetics. This is aficamten. It's a phase 2 trial, and there have been 4 cohorts. We've completed 3 cohorts, and in the first 3 cohorts, I'm pleased to report that UCSF HCM program is the #1 enroller worldwide. These interim results were reported at HFSA earlier this year. 41 patients, 10 weeks of treatment. Everybody had significant reduction in gradients, as you can see in the graph here. 93% response in the high dose cohort, 58% response in the low dose cohort, compared to 8% response in those who were on placebo. The next follow-up study is from Redwood, is another large tree, the Sequoia. The anticipated start date is March 2022. This is a phase 3 study of aficamten. It's a randomized placebo-controlled double-blind multi-center study. It seeks to enroll 270 patients who will be randomized 1-to-1 to 24 weeks of placebo versus therapy. The endpoints are VO2 max, New York Heart Class, and LVOT gradients. I'm going to go, in the interest of time, do some quick bites here. Talk a little bit about non-obstructive HCM that I've mostly ignored for the majority of the talk, and talk about 3 studies that are upcoming or have just completed. I'm not going to talk much about gene therapy. There is a study that's about to start, gene therapy for myosin binding protein C mutations. I'm not going to touch on that today. And lastly, interspersed here, I'll mention a few words about ongoing research on mechanics and how that relates to what we're doing next, and computational flow modeling that I'm very excited about. So on the left-hand side here, Maverick is a study that was just reported. Patients with non-obstructive HCM were placed on mavacamten therapy, and you see that there was reduction in biomarkers. The change in symptoms was not that remarkable, and the endpoints were really biomarker endpoints. So we're waiting to hear more about this. Very few patients, I believe there are 20 or 30 patients placed on mavacamten. This is a study that has just started. Currently, we are the #2 enroller for this study. It's called IMPROVE, and it's looking at an agent that is a fatty acid oxidation inhibitor. And what that does is increases the amount of ATP production per molecule of oxygen. And the hope is that that will improve the energetics in the heart regardless of hemodynamics. But this is targeting non-obstructive patients at this time. So we're waiting to hear more on how this pans out. I'm going to segue here into some of our research, and this was done by Heracles when we're still at Hopkins. We found that non-obstructive HCM has more events. If you looked at VTVF, both historically as well as prospectively in a 3-year period, non-obstructive HCM had a lot more VTVF incidents compared to labile and obstructives. If you looked at folks who had appropriate ICD discharge, there were significantly more appropriate ICD discharges in non-obstructive, 0 in labile obstructive, and a few in obstructive. So there was a signal here that arrhythmic events, and in fact, total events, this is a composite event-free survival for death, heart failure, stroke, atrial arrhythmias, and ventricular arrhythmias. If you looked at all of them, Again, non-obstructives were much worse off even after adjusting for a whole host of clinical and imaging factors. So we said, if they have more events, what is going on, and is there a pathophysiologic basis for that? And the answer is yes. We know that there's the intramural coronary arteries may be involved in HCM, and there's varying degrees of myocardial fibrosis, and both these can be tracked by imaging markers. So the intramural coronary arteries have a lot of hyperplasia, hypertrophy, and fibrosis, and that could result in reduced perfusion flow reserve that can be tracked with techniques such as ammonia PET that I referred to earlier in the talk. How about fibrosis? We can use contrast MRI to track fibrosis. And that's exactly what we did. And if you look at scar burden, you see that non-obstructive patients had much larger scar, on average, much larger scar compared to obstructives and labile obstructives. And the percentage of patients with a significant scar burden was again very high in non-obstructives compared to labile and obstructives. So scar is larger and more people have significant scar if you're non-obstructive. What about perfusion? If you look at the percentage of patients with microvascular ischemia, it's substantially higher in non-obstructives compared to the other groups. So if you were to map this out and you look at hypertrophy, SAM, scarring, microvascular ischemia, and VTVF, what you find is that for equivalent amounts of hypertrophy, non-obstructives have more scar, more microvascular ischemia, and significantly more frequent VTVF events. So based on that, we proposed, and we are hoping we did get a good score below the fundable score for last year, and we're hoping to hear good news on NIH funding for this proposed study, which is called Excite HCM, which is exercise training, and we're trying to see if a non-medical means, exercise training, actually can influence microvascular perfusion, which we will test with ammonia PET, influence cardiac mechanics because the perfusion is better, and as a result of better perfusion and better mechanics, that your exercise capacity gets better. 70 patients will be randomized to either moderate density exercise or little or no exercise. Moving on, another topic of interest that I want to touch upon is patient-specific modeling using machine learning means. And we did some of this, and you can model how the mitral valve behaves. We know that in obstructive HCM, there's exquisite and a huge variety of mitral valve problems. And the other thing is looking at Doppler. There's an entity called as virtual Doppler that you can do using AI and ML off of computational flow modeling. And this is in a normal volunteer. If you don't use Doppler and just use AI, you get a virtual Doppler that's exactly the same, very similar to echo-based Doppler, true Doppler. So there are things that you can do, higher dimensional investigations that might allow you to get a lot of information on flow. And the problem in HCM, for most part, is some problem with flow. There's a problem with inflow in all types of HCM because you've got a stiff heart and a thick heart. There's problem with outflow in all the obstructive varieties of HCM. And you can use three-dimensional flow modeling and derive a lot of exquisite information about flow vortices, et cetera. Using that, what we're hoping to do is, again, use this three-dimensional flow modeling to derive a lot of vorticity contours and velocity information. And the interesting part here is using this three-dimensional information, you can get novel Doppler variables. One, they're 3D based. Two, they're agnostic of direction. So you don't care if your Doppler sample is lined up at the maximal flow velocity. And you can now get transmitral velocities. You can get pressure gradients that are three-dimensional and tissue motion. More importantly, all this allows us to get new, previously unavailable variables that are also three-dimensional based, such as wall stress or shear stress, vortex propagation, energy dissipation of the fluid, and lastly, residence times. How much time does the blood spend in particular portions of the heart? And this has huge impact on people who might develop clots, especially in apical HCM. And of course, those implications also apply for other varieties of heart disease. So to summarize and to end the talk here, from mechanics to myectomy to modulating myosin, what I hope I've shown is that HCM is a very common inherited heart disease. Imaging is operative in multiple components of HCM, whether it's diagnosis, prognostication, monitoring therapy, and we do focus on multimodal imaging. This is the HCM heart, and you can see that a third of the patients are non-obstructive. And those folks end up with medical therapy, either conventional medical therapy, guideline-directed medical therapy for heart failure, or maybe we're hoping that in the folks that don't have low EF, that we will be able to come up with some novel therapies for them. If none of those work, of course, they're headed towards a transplant. Obstructives, who are 2/3 of them, and I hope I've given you a wide variety of options here. Surgical myectomy, the classic surgical myectomy or modifications thereof, alcohol ablation or RF ablation, and lastly, novel drug therapies that I think are having equivalent, if not better results than any of the other options. This is a team sport, and I want to recognize several people. Most of these folks are at Hopkins, except where it's noted, and they've helped us do so much, and certainly could not do this without their help. Lots of our UCSF folks, starting with Tolstrup, Kasem, Watt, and Sabanayagam, who have helped us immensely in doing this, and a whole host of other folks who help us clinically and in our research portfolio. And lastly, I know this is probably the last grand round for the holidays, so happy holidays to one and all, and have a safe, wonderful holiday, and a renewed thanks to our fantastic HCM team. Call us if you have any questions about HCM or would like your patients enrolled in an HCM emerging therapy trial. And remember, just as the great American philosopher Charlie Puth once said, we're only one call away. That's our phone number. I'll stop there. Happy to take questions. And thank you, Joyce, for having me do this grand rounds.
Thank you, Dr. Abraham. That was an amazing talk. I have a question here from Dr. Redberg. I'm not sure if you want to ask it in person.
Sure. I was just a great talk, and wonderful to hear about all the work and the team's work. I serve on the California Technology Assessment Forum, which is part of the Institute for Clinical and Economic Review, and our last meeting was on hypertrophic cardiomyopathy. And in the discussion of the Explorer trial and mavacamten, there was a lot of concern about the reduced ejection fraction in the mavacamten arm, leading the committee to, I think, to vote promising but inconclusive. There were also not a lot of comparative effectiveness to the other disopyramide, et cetera. But I'm wondering what you think about the reduced ejection fraction, which I think was 4% compared to no change in placebo.
Thank you, Rita. A great question, and that was our concern even when we decided to get involved in this study. We've had a couple of patients. We've had, as I said, we contributed a large number. We had a couple of patients who did have EF drops, and most of those are transient. We, however, did have, I think, 1 or 2 patients who had to permanently stop it. The trial criteria said was, if your EF dropped below 50, that you could be stopped or dose reduced transiently, and if your EF came back above 50, you could restart the drug. And there was one patient, certainly that I can remember, who dropped below 30, and that was a permanent stop. So I think it's a concern. I think monitoring is very important. Also, if other things are happening, we had one patient, for example, had a stress cardiomyopathy coincident with all this, and their EF dropped. Now, we don't know if it was a stress cardiomyopathy or the myosin ATPase inhibitor or the setting of both being operative that resulted in that. So certainly we need more post-market surveillance or long-term the surveillance on the long-term extension patients. Number 2, I'd say that aficamten, the new drug, just reported on the first 41 patients. And out of 41 patients, they had only 2 patients who transiently dropped below 50, but not below 40. And both actually got back on drug and completed the study. The difference is, and I don't know if this will become a meaningful difference, is that aficamten actually has a much wider therapeutic window. So the PK/PD kinetics are much more acceptable, so that for a wider range of dose increments, the steepness of the drop in EF is blunted. So those are my comments. I'd say that for most part, if you monitor the patients closely and are able to catch this decrease, we have not seen anybody have a problem with it. But it is certainly an extension of the therapeutic effect and needs to be watched for closely.
Thank you. I have Dr. Chorba who would like to ask a question.
Yeah. So I was really intrigued by your comments the point that like when you give the infusion of the alcohol and the septal ablation, like you get the reduction of the obstruction just like so quickly. And so it makes me like wonder, like, you know, with an alcohol septal ablation, right, you just kill the heart. And so you kind of induce these problems of like cell death. Has anyone ever tried like just figuring out some way to just like permanently poison the myosin interaction so you don't like kill the cells in the septum, but then because presumably if it happens so quickly, the major issue is just the reduction in the squeeze, as opposed to like, you know, immediate cell death in that time frame. I'm curious.
So thank you for the question and the comment. There's really two aspects. I mean, I guess I would have two answers to it. One is there may be cell death, but the immediate effect is probably just because the cells are dead and not functioning. The long-term effect is that the cells actually atrophy and you see thinning of the septum, and that's what's hoped for. It doesn't happen consistently, but that's true. And I think people are looking at it. I reviewed, I think, either an R01 or something for the NIH where they had some cytotoxic agent that they were going to use to try to deplete the cells. So to your point, yes, people have tried either ablation or, you know, cytotoxic therapies. Ablation is being used clinically. The cytotoxic therapy, I think, they've been trying it in a sheep model and in a mouse model. I hope that answers your question.
Thank you. Dr. Priscilla Hsu has a question. She asked, any data on the ability of mavacamten to reverse remodeling after you have the disease?
So thank you, Priscilla, great question. And that's obviously something. So the two questions we want to know is, once, is there reverse remodeling? And more importantly, is there some disease modification even on top of that at a fundamental level? And the answer is we don't know, but there is a signal. There was a paper in CIRC a few months ago using MRI, and they showed a decrease in septal wall thickness. We have a paper that just came out, I think, yesterday online with echo that showed maybe a no change in wall thickness to a signal towards a decrease. I think that all these studies were 30 weeks and it's too early. And if you actually look at the raw data, the scatter plots are all over the place, and the average and the means are being driven by outliers. So I'd say you would need, for the wall thickness and the reverse remodeling issue, ideally you would need maybe at least a year, maybe or more. Mavacamten will have almost a year's worth of data or more, and I think they're looking at that. So our hope is that there's a decrease in wall thickness.
Dr. Nora Goldschlager had a question regarding ICDs prophylactically. Does this information inform any new criteria for ICD implantation?
I'm assuming the information refers to mavacamten or image and mavacamten. Okay, so the answer is no. I guess the original criterion guidelines still hold good. Nobody has suggested or is offering that they would alter the risk for sudden cardiac death or ventricular arrhythmias.
I was wondering, I think you mentioned one of the contraindications for septal ablation are the other physiologies, so more apically. Do you foresee any of these imaging modalities, particularly the ones you talked about, helping guide whether or not there are other arteries that can be targeted during septal or during ablations, alcohol ablation, or even radiofrequency ablation?
Yes, I mean, I think theoretically the answer is yes. In reality, I would say unless you have classic, localized, very focal basal hypertrophy with a septal SAM contact occurring in the true base, you are ideally not a candidate for septal ablation, because all other varieties are more global. That is, it's not one little knob sticking out in the mid-ventricle that's causing the obstruction. It's because you've got a huge midventricular hypertrophy. So let's say you went and you found a middle septal perforator and obliterated that septum, the mid septum, the mid lateral wall, the mid inferior wall, the mid anterior wall will still come in and do that. So I would say that would be not best practice to do septal ablation in folks who do not have classic focal hypertrophy at the base.
Thank you. I think I see the conference room might have unmuted. I'm not sure if anyone in the conference room has a question. If not, then I will let everyone go a little bit early. And thank you again, Dr. Abraham, for the great talk. And happy holidays to everyone. I think our next grand round will be in the beginning of January. So I hope you guys have a safe and wonderful holiday season.
Thank you, Joyce. Happy holidays to all. Thank you.